Good day everyone, I am Dr. Robert Glenn Abisamis and welcome to my lecture on endocrine diseases part 2. So before we begin, here are a few disclaimers and some important reminders. Our main textbook and main reference for this lecture is still Robinson Cotton's Pathologic Basis of Disease, the 10th edition. Images are from the textbook above and the following resources unless stated otherwise. So I'm using multiple books for the pictures only, but the main text is from Robbins. So first, for endocrine 2, we will be discussing the pancreas, both endocrine and exocrine, and then the adrenals, inherited syndromes, familiar syndromes, and your pineal glands quite briefly. So first, we begin with the discussion with endocrine pancreas. So to begin, the endocrine pancreas contains a lot of clusters of cells called the islet of Langerhans. So yun yung pinaka-importanting structure in your endocrine pancreas. So we'll be discussing the exocrine pancreas later. Major cell types include your beta cells, alpha cells, your delta cells, and your PP cells. So the following functions of these cells are listed in here. And you have to review your basic endocrinology to know kung anong ginagawa ng hormones na pinoproduce ng mga cells na to. Basically kasi, when you're dealing with endocrine pathology, it's just a question of balance. So, ang question is there something causing a decrease of this hormone, and naturally kung ano yung ang clinical manifestations mo would be kung ano mangyayari kung wala yung hormone na yon. And the reverse is also true. Kung sobrang dami ng hormone mo, ano mangyayari sa pasyente mo? Very predictable siya yung mga clinical features mo based dun sa alam mong function ng hormone mo. So that's why you need to know your basic endocrinology here. Okay, so for the endocrine pancreas, there are just two main topics that you need to know. Number one would be diabetes, which is everyone should know about diabetes. All medical doctors should know about diabetes. And the second one would be your pancreatic neuroendocrine tumors, or your PANNET. We'll be going over a few of the PANNETs later. It's not quite common compared to diabetes. Kaya if you're gonna ask me kung saan kailangan mag-concentrate, it has to be DM. So first, let's discuss DM. DM is a group of metabolic disorders characterized by hyperglycemia due to defects in insulin secretion and or insulin action. And the chronic hyperglycemia yung binabantayan natin because that is the one causing the damage to your multiple organs. In the US alone, it's the leading cause of end-stage renal disease, adult onset blindness, and non-traumatic lower extremity amputations. Same din dito sa Pilipinas, we get a lot of the patients na we're seeing the sequelae of uncontrolled diabetes resulting into persistent hyperglycemia. Ang hyperglycemia kasi yun ang nakakasama dito. In the US, more than 9% of the population would have type 1 DM. The rest would already have type 2 diabetes. 84 million adults in the US are pre-diabetic, meaning they have elevated blood sugars but do not meet the criteria for diabetes. Think of pre-diabetes as yung parang isang tumbling na lang, overt diabetic ka na. Okay. In the entire world, a lot of people are affected. Around 422 million ang approximation ni Robbins by the time of publication. And the main contributors kasi is the increased sedentary lifestyle, poor eating habits, causing your diabetes epidemic. We can guess dahil especially ngayon na pandemic mode pa rin as of the presentation, people have more increased sedentary lifestyle kasi nga majority already work from home. So yun yung main concerns during diabetic in terms of our health. So how do you diagnose diabetes? So you have to know that the normal blood glucose levels in your body is around 70 to 120 milligrams per deciliter. For you to qualify as diabetic, you have to be at least one of the following, one of any of these diagnostic criteria. So, FBS mo is more than or greater than or equal to 126. RBG, or rapid plasma glucose, rapid blood glucose, should be more than or equal to 200 milligrams per deciliter. Plus, your patient should be manifesting with signs of hyperglycemia. If you're going to do your oral glucose tolerance test, ang loading dose mo dapat is 75 grams. And when you collect your glucose levels 2 hours later, it's more greater than or equal to 200 equals diabetes na. And then you have your HbA1c level, which is greater than or equal to 6.5%. Now, with these tests, it needs to be repeated and confirmed on this different day. Remember kasi that there are several factors that may affect kung bakit tumataas ang glucose mo. So, for example, random plasma glucose mo for today is, chinek mo, is more than 200 milligrams per deciliter. So, kailangan, the following day or the following week, okay, even on, basta on a different day, kailangan consistent yung value na yon, or even higher, para ma-confirm mo yung diagnosis ng diabetes. If there are discordance between two different tests, for example, nagpasabay kayo ng FBS or HbA1c level, kung merong isa doon ang deranged, yun ang ko-consider mo na result. Because it's better for you to be more worry about diabetes. Mas likely na mas gusto mo na mag-treat ng diabetes kaysa sa hindi ka mag-treat at all at pinabayaan mo yung hyperglycemia. Okay? So, yun nga. Ang main issue kasi with these tests is acute stressors can lead to transient hyperglycemia. So, it has to be persistent hyperglycemia on different days in order for you to diagnose. Now, what about prediabetes? So, prediabetes, ito yung if your patients fall in here in this state, you can still say na, pwede ka pa mag-lifestyle modification para ma-treat mo para hindi mag-progress into diabetes. So, is defined by one or more of the following: FB, fasting blood glucose between 100 to 125, 2-hour plasma glucose between 140 and 199 milligrams per deciliter, if being given a 75 grams na loading dose dito sa 2-hour glucose ito. And then yung HbA1c levels is between 5.7 and 6.4%. And around 1/4 of the individuals with these laboratory tests will be progressing to over diabetes in under 5 years. So, diabetes is classified in, classically, you divide diabetes into two types. Yung type 1 diabetes and type 2 diabetes. And both have the same feature. It's hyperglycemia. Dati, meron tayong tinatawag na juvenile onset at adult onset. But right now, the current classification is just based on the pathogenesis. So, for type 1 diabetes, ang characteristic niya is beta cell destruction and absolute deficiency in insulin. Ito yung tinatawag dati na juvenile onset because the diagnosis is usually done in patients younger than 20 years of age, but it's not true. Anytime that your patient has diabetes secondary to beta cell destruction ng pancreas mo, for example, nagkaroon ng patient ng acute pancreatitis, we'll get to that later, mangyayari is baka masira din pati yung beta islet cells mo. Pag nasira yung beta cells mo, wala kang insulin na ipoproduce. So, in effect, you have type 1 diabetes. Now, with type 2, on the other hand, this is caused by mainly peripheral resistance to insulin action. Or you have a secretory response by pancreatic B cells inadequate to overcome insulin resistance. So, either yung insulin mo ay, yung katawan mo is resistant to insulin, or yung insulin na pinoproduce ng katawan mo is less than the adequate. So, in other words, meron kang insulin sa umpisa to begin with. Majority of diabetics fall under type 2 DM. And classically, this is considered as adult onset, but not anymore as well. Hindi na natin ginagamit yung adult onset DM. Hindi na rin natin ginagamit yung insulin dependent kasi we all know na pag pinabayaan mo, even type 2 na pinabayaan mo, you will need insulin as well. So, hindi na rin ginagamit yun as basis for classification. In Robbins, here is this is a list of all possible etiologies of your diabetes. So, ito yung sinasabi natin na ito yung classical na na classification diabetes mo yung type 1 and type 2. But it has been found out that several other conditions can also cause diabetes, and that is what you have to be wary of as well. So here is a table showing you the comparisons between type 1 and type 2 DM. We'll go over these later, but this is a good overview kung ano ang pagkakaiba ng type 1 sa type 2. Basta tandaan nyo, si type 1, autoimmune, sisirain niya si beta cells mo. Si type 2, more of we're dealing with insulin resistance. So, now's the time that we have to review glucose homeostasis, ang role ng insulin sa katawan natin. Okay. So, with regard, glucose homeostasis is regulated by 3 interrelated processes. You have your glucose production in the liver, you have your glucose uptake and utilization by your peripheral tissues, and the actions of insulin and counter-regulatory hormones on glucose uptake and metabolism. So, if you are in a fasting state, for example, may sabihin matagal kang hindi kumakain, ang response ng katawan mo should be low levels of insulin and high levels of glucagon. Remember that ang function ng insulin mo basically is to transfer glucose from your blood to your tissues. Glucagon yung baliktad. So, ang point ng fasting state mo is to mobilize sugar, to mobilize glucose in your body. So, it does this via the processes of hepatic gluconeogenesis. So, yung mga glucose stores sa liver is going to be broken down and be released into the blood, and you have to decrease glycogen synthesis. So, in order to prevent hypoglycemia. Okay? In a meal state, however, kung makain ka, ang mangyayari, the insulin levels rise in response to the increased levels of glucose in your blood, and the glucagon levels fall. In other words, ang goal ng katawan mo ngayon in a meal state is to transfer the glucose from your bloodstream to your tissues. Yun yung gusto mo. Okay. So, ang major insulin responsive site is your skeletal muscle. Other sites na very important is your brain and your adipose tissue. Now, how about insulin? Insulin is produced by your beta cells of the pancreatic islets as a precursor protein, and it is cleaved in the Golgi complex to generate your C-peptide. Now, the insulin and C-peptide are stored in secretory granules and are released in equimolar quantities during physiologic stimulation. The most important stimulus for insulin synthesis and release has to be glucose. So, anytime na tumaas ang glucose levels sa katawan mo, in your glucose dapat magkaroon ka ng glucose uptake in your pancreatic beta cells facilitated by the GLUT2 receptor, as you can see over here. And then, during the first stage of insulin secretion, i-metabolize ang glucose mo, and therefore it will cause increase in ATP, influx of calcium ions, and then you will have stimulation of insulin secretion. Once you have secretion of if nagpa-persist yung secretory stimulus mo, then your body will undergo active synthesis of insulin para meron siyang maibigay na extra insulin sa katawan, and therefore ma-transfer lahat ng glucose na yan dun sa loob ng cells mo. So, when you have oral food intake, there are other hormones that are actually being released aside from insulin na needed for glucose homeostasis and satiety. So, kailangan din malaman ng katawan mo na, hoy, tama na ang pagkain mo. That is satiety, yung feeling na busog. So, you have dito papasok yung incretins mo. Okay? Their incretins are an important class of hormones promoting insulin secretion after feeding. So, ang kasama dyan would be your GIP and your GLP-1. And elevation of this is what you call the incretin effect. So, there's a long discussion in Robbins, pero ang pinaka summary niyan is, by increasing this GIP and GLP-1, you are causing satiety. Pinabubusog ka. Dapat nabubusog ka after feeding. So, ang magme-message niyan ay itong mga hormones na to. Okay? And eventually, your body will also release DPP-4 So that degrades ito yung parang counter-regulatory hormone mo, yung DPP4, to degrade your GIP and GLP-1. In type 2 diabetes, ang type 2 diabetes, the incretin effect is blunted. Wala yung elevation ng incretin sa to. So, you need to restore incretin function in order via improve glycemic control and promote weight loss. And drugs developed to tackle this is your GLP-1 receptor agonist and DPP-4 inhibitors. To make the long story short, what you want is for your incretins to work. And if it works, ibig sabihin, nabubusog ka, hindi ka kumakain tuloy. Yun yung point ng incretins. Now, let's go now to insulin per se. Insulin is the most important anabolic hormone known with multiple synthetic and growth-promoting effects. The principal metabolic function is to increase the rate of glucose transport into certain cells, in which glucose acts as the energy source for these cells. The important targets are your striated muscle cells over here and your adipocytes. In adipocytes, however, it's classified into two, yung beige and yung white. Yung beige adipose tissue is the one that utilizes the most glucose and develops with exercise. So, kaya sinasabi natin sa patients natin that exercise is very beneficial to preventing or overcoming diabetes. The white adipose tissue is the one being accumulated in obese individuals, and therefore obesity is detrimental. In adipose tissue, the glucose is used as a substrate for lipids and it's stored as triglycerides. So basically, ang store ng katawan mo ng glucose could be in the form of your triglycerides via a very complicated biochemical procedure. The anabolic effects of insulin includes inhibition of triglyceride hydrolysis and lipid release in adipocytes, promotes amino acid uptake and protein synthesis and to degrade proteins degradation, and you have other mitogenic activities. So here is a good diagram showing you the role of insulin in these sites. Ang pinaka-basic nito is insulin promotes glucose uptake. So, dadami ang adipose tissues mo, lalaki ang adipose tissues mo. For striated muscles, magagamit yung ginagamit nga dapat yung glucose uptake mo, especially if you're exercising, and yung liver mo, it's not going to store yung glucose mo dito. The metabolic effects of insulin are exerted through binding of the insulin receptor. This is your insulin receptor over here, and it's composed of a tetrameric protein composed of 2 alpha subunits and 2 beta subunits over here. The beta subunit ito is the one that possesses tyrosine kinase activity, as you can see over here. Now, let's discuss the pathogenesis na of type 1 and type 2 DM. So, for type 1 DM, as I mentioned earlier, it's due to autoimmune disease in which you have islet destruction due to having all immune effector cells reacting against endogenous beta cell antigens. So, this manifests usually during childhood. Kaya the initial term na ginagamit for this is juvenile onset diabetes, pero hindi na siya ginagamit. Pati rin yung term na insulin-dependent DM, hindi na rin ginagamit kasi other forms of diabetes would also require insulin. The pathogenesis involves interplay of genetic and environmental factors, and we'll be discussing that. With regards to genetic factors, it has been studied that the most important locus is the HLA gene cluster, contributing as much as 50% of genetic susceptibility. 90 to 95% of Caucasian patients have the HLA-DR3 or HLA-DR4 haplotype. And merong ding compound heterozygotes na with DR3, DR4 that are around 40 to 50%. However, there are also other non-HLA genes conferring susceptibility. So, one would be variable tandem repeats in the promoter region of the insulin gene, polymorphisms in CTLA4 and PTPN22, and autoimmune thyroiditis. Some patients na may autoimmune thyroiditis also have type 1 DM dahil dito. And then, type 1 DM and its relationship to altered T cell selection and regulation. So somehow related din siya with the production of your of causing type 1 DM. Environmental factors, we know that there's a possibility, pero kung ano eksakto hindi pa sigurado. One that they're studying is viral infections, question mark, because they might share epitopes with islet antigens and the immune response to the virus. Meron kang cross-reactivity, and therefore that was causing the destruction of your islet tissues. And certain infections are thought to be protective against type 1 DM. So this is still uncharted territory. So how do you how does one convert to having type 1 DM? Paano ba nasisira ang beta? So we will discuss the mechanisms of beta cell destruction kasi yun yung main hallmark ng type 1 DM. The clinical onset is abrupt, but there is a lengthy lag period between the initiation of the autoimmune process and the onset of symptoms. So matagal between nag-start yung autoimmune process, sisirain yung beta islet cells mo, and then from the start of symptoms mo. There are 3 distinct stages. Stage 1 is autoimmune positive na yung pasyente mo, pero normal glycemic pre-symptomatic DM. So meron ka ng antibodies that can be detected at this point in time. In stage 2, doon ka na nag-umpisa na may dysglycemia ka na. So parang kumbaga, if you're going to do laboratory tests, you may see already parang pre-diabetic levels ng DM mo. Nagkakaroon na ng increased loss of glucose tolerance due to loss of the beta cell mass. Pero there is still no frank symptoms at this point in time. And from stage 1 to stage 2, it's around 5, tumataas ang rate to developing symptoms from 50% to 75%. It's when you are in stage 3 na kung saan meron ka ng symptoms, outright symptoms sa patient mo. And by this time, the beta islet cells are around 90% destroyed na. So in Robbins, this is a good graph showing you the progression from stage 1 to stage 3. So if you will notice dito, yung beta cell mass mo, meron ka ng decrease here at the stage 2, but have no symptoms pa at this point in time. It's only when 90%, around 90% na yung destroy beta islet cells mo sa pancreas mo, tsaka ka lang nagkakaroon ng symptoms. The fundamental immune abnormality is the failure of self-tolerance in T cells specific for islet antigens. This may be a result of some combination of the following: either defective clonal deletion of self-reactive T cells in the thymus, defects in the functions of regulatory T cells, and abnormal resistance of effector T cells. So basically, yung T cells ng katawan mo ang nagagalit doon sa islet antigens, tapos sisirain niya ngayon yung beta islet cells mo. Okay. So, this is an example of a late phase type 1 DM. This is this is your islet cells marked by glucagon. So, ito yung alpha cells mo. And when pag nasa diabetes ka na, as you can see over here, wala na yung yung beta islet cells mo at this point in time. That's for type 1. So basically autoimmune. In type 2 naman, it's a very complex disease involving interplay again of genetic and environmental factors plus a pro-inflammatory state. Genetic factors baka likely na meron since they see na there is a very high concordance between monozygotic twins and between first degree relatives. However, there are a lot of foci, loci that confers lifetime risk, around 30. So, you can't pinpoint one genetic cause for DM. Mas importante though for type 2 DM are your environmental factors. And the most important environmental risk factor is obesity, whether visceral or central ito. More than 80% of individuals with type 2 DM are obese, and obesity contributes to the cardinal metabolic abnormalities of DM and to insulin resistance. if your patient has a sedentary lifestyle, like katulad natin mga medical students and na nasa bahay na lang ngayon, weight loss and exercise are usually increase insulin sensitivity and additively. So that's why you recommend to do kahit na 30 minutes sa exercise, kahit nasa bahay lang kayo. These are first line interventions in patients with mild type 2 DM. And if your patient has developed metabolic syndrome, which means your patient has obesity, hyperglycemia, increased serum cholesterol and triglycerides, and hypertension, yun talaga nagpapataas ng risk for your DM. Okay. So, it has been found out that type 2 DM rates are increasing also in populations even if there are no comparable increases in obesity rates. It's probable that race is has a contributing factor due to anatomic distribution of fat between the different races. So, kung kukumpara mo yung mga East Asians, parang sasabi nila parang visceral ang ano nila, pero visceral obesity sila, pero ano pa rin, tumataas pa rin ang rate sila. So, it could be isang in-explore is the westernization of diet. Isa yun sa mga kino-consider na possible environmental factor. One other factor is sleep na possibly contributory would be the sleep disorders as circadian disruption. So when you say circadian disruption, it means that there is a misalignment between the endogenous circadian rhythm and the cycle of rhythm created by individual behaviors. So this is a very usual, like with us, especially yung mga nung mga nagdo 24-hour duty, yung mga night shift, like yung mga call center agents, ganyan, those people with sleep disorders, so for example, sleep apnea and other conditions that can restrict nighttime sleep and daytime wakefulness. And what happens is there in patients with sleep disorders, there is an impairment of glucose homeostasis by affecting insulin secretion and action. That's why it's very recommended na kailangan if our patient has a sleep disturbance, you need to correct that as well. Metabolic defects, there are two key abnormalities in the development of type 2 DM. One is insulin resistance and the other is beta cell dysfunction. In insulin resistance, you have decreased response of your peripheral tissues to insulin. So, remember na insulin primarily affects on your peripheral tissues such as your muscles. So, pag wala kang insulin, pag konti ang response ng insulin mo on the peripheral tissues, then you have a hyperglycemic state. Hindi pumapasok kasi ang glucose mo to the cells. And then you have beta cell dysfunction, which means you have inadequate insulin secretion in the background of insulin resistance and hyperglycemia. So it's kind of a vicious cycle na kung saan wala ka na nga, hindi yung peripheral muscles mo na nga, hindi ka na wala ng normal insulin response, so hindi ka na nga nagkakaroon ng uptake. Tapos hindi pa maganda secretion mo, so kulang ka din ng insulin. So kung kulang insulin, your insulin is not working equals hyperglycemic state. And that's what you don't want. When we talk, as I've mentioned kanina, insulin resistance means it's the failure of target tissues to normally respond to insulin. And your major peripheral tissues mo will be the liver, skeletal muscle, and adipose tissue. If you have insulin resistance, it results to the following. You have failure to inhibit endogenous glucose production in the liver, causing high fasting blood glucose levels. You have failure of glucose uptake and glucose synthesis to occur in skeletal muscles after meals, so mataas ang postprandial glucose levels mo. And there's a failure to inhibit activation of your hormone-sensitive lipases in adipose tissue, so mataas ang levels of circulating free fatty acids mo. The mechanisms behind insulin resistance are varied. They are one of the more famous mechanisms is that there is reduced tyrosine phosphorylation of the insulin receptor in IRS proteins in the peripheral tissues. That compromises insulin signaling and therefore that results to a reduced GLUT4 on the cell surface. Wala kang GLUT receptor, walang transfer ng glucose mo. Exercise can improve the insulin sensitivity by increasing translocation of GLUT4 to the plasma membrane, causing decrease in your glucose levels. Obesity, again, as I mentioned earlier, is the most important contributory factor to insulin sensitivity. So, kapag yung mga patients that are centrally obese or abdominal yung distribution ng fat nila is more likely to be linked with insulin resistance than the peripheral, yung nasa gluteal or subcutaneous. In patients from Asia and the Middle East, who develop diabetes are seen to have more visceral fat. So, inisip nila that in this population, visceral fat confers an increased risk in your diabetes. Now, for subcutaneous adiposity, ang sinasabi lang niya is there's relative protection from diabetes. Pero in general, you don't want a lot of fat in your patients. Other impacts of obesity includes the inverse correlation between fasting plasma, free fatty acids, and insulin sensitivity. So, pag mataas ang free fatty acids mo, bagsak ang insulin sensitivity mo. Therefore, you are more insulin resistant. Yun yung ayaw natin. So, the excess in free fatty acids overwhelm the intracellular fatty acid oxidation pathways, causing accumulation of cytoplasmic intermediates. And those intermediates attenuate signaling through the insulin receptor and activates the inflammatory pathways of the islets. This is why obesity is a pro-inflammatory state. And if you have a lot of pag mayroon kang inflammatory state in your islets tissue, that's going to destroy your beta cells. Adipokines are proteins secreted by adipose tissue, and kasama dyan will be your leptin and adiponectin. So those two, essentially these are hormones secreted by fat. So, these two are decrease the blood glucose by increasing insulin sensitivity, and during the obesity state, decrease ng adiponectin mo. Last would be the beta cell dysfunction. So, this is required for development of overt diabetes. Kasi, kanina we're just discussing about insulin resistance. So, it's more of a peripheral problem. This time, we're talking about a secretion problem na kapag meron ka ng dysfunction ng beta cells mo. So, initially, there is an increase in your beta cell function as a compensatory measure to maintain your glycemia. But eventually, these cells exhaust their capacity to adapt to long-term demands to insulin resistance. So, pag pagod na yung beta cells mo, hindi siya produce ng insulin mo. Kaya, essentially, kulang ka ng insulin na nilalabas. The cause of these dysfunctions are the mechanisms for causing beta cell dysfunction are the following: lipotoxicity, glucotoxicity, abnormal incretin effect, amyloid deposition in the islets. We'll see that later. And you have polymorphisms also within the genes that control insulin secretion. Tapos tayo sa discussion ng pathogenesis ng type 1 and type 2. But there are also monogenic forms of diabetes. So, ito yung mga tipong may isang gene ka na pwedeng sisihin kung ba't nagkaroon ng diabetes ang pasyente mo. Number one are, one would be genetic defects caused in beta cell function, and the other one are genetic defects that impair tissue response to insulin. So number one, kung wala kang beta cell function, wala kang insulin na pinoproduce. So this is seen in mostly maturity onset diabetes of the young due to germline loss of function mutations in the following. Ito yon. And the other one, which impairs tissue response to insulin, these are quite rare. So, frankly, I have never seen these causes of diabetes in my practice. Pero what you will see in your patients is hyperpigmentation of the skin, polycystic ovaries, and elevated androgen levels along with your diabetes. During pregnancy, DM is also an issue because either because yung pasyente mo is diabetic na prior to being pregnant, so women has a pre-existing diabetes, you call that pre-gestational or overt diabetes. And then the other one na talagang hinamanage talaga ng OB would be gestational diabetes mellitus, in which the woman is euglycemic, and then during pregnancy nagkaroon ng diabetes. Bakit nagkakaganto? In pregnancy in itself is a diabetogenic state because there's the prevailing hormonal milieu that favors insulin resistance. Ang problem mo is if you do not control the diabetes in the patient, you may have either increased risk for stillbirth and congenital malformations, or your babies end up being macrosomic. Yan yung mga extremely large babies, large for gestational age na baby sa pinanganak. Sobrang cute nila, pero pag nakita mo yung baby na yon, you'll think na, oh my god, diabetic siguro si mother. Okay? So, if it's GDM, meaning nag-develop lang ang diabetes habang buntis si mother, it should resolve after delivery. Pero note that the woman can develop overt DM in around 10 to 20 years. So, what is the criteria for gestational diabetes? So, we have a local guideline here by the society mismo ng OB-GYN here in the Philippines. So this was released in 2011. FBS should be greater than or equal to 92 milligrams per deciliter, and your 2R OGTT with 75 milligrams loading dose should be greater than or equal to 140 milligrams per deciliter. Please take note na ito lang ang acceptable na criteria for gestational DM. Kasi ang problema is you're trying to determine if your patient develop diabetes only during pregnancy. So HbA1c doesn't work. We'll discuss HbA1c later. So, for clinical features in type 1 DM, they may arise at any stage. There's an initial 1 to 2 year, during 1 to 2 years after onset of diabetes, there's the exogenous insulin requirements may be minimal due to residual insulin secretion, pero eventually, pag-destroy nyo talaga yung beta cell function mo, tataas na yung requirement for insulin, therefore, kailangan na magkaroon ng exogenous insulin na ini-inject to type 1 DM patients. For type 2 DM patients, your patients are usually obese, greater than 40 years old. Pero right now, we're seeing younger patients, even children, developing type 2 DM due to obesity and sedentary lifestyles. In some cases, mapasok yan sa clinic o kaya sa ER because of unexplained fatigue, dizziness, or blurred vision. And more often, the diagnosis is just due to routine blood testing. So, nagkakaroon, in many countries, including here in the Philippines, annual wellness checkups also include testing for diabetes already. Whether it's via the use of FBS or via the use of your HbA1c. Hindi ang glucose tolerance test dito sa Pilipinas, mas ginagamit siya ngayon, mas reserved siya for OB use, yung GDM na diagnosis natin, rather than using it for any other person na may diabetes. Now, the classic triad of your diabetes is polyuria, polydipsia, and polyphagia. And if severe, a manifestation is usually diabetic ketoacidosis. So, how does these three symptoms develop? So, if you have hyperglycemia, there is filtration of so much glucose in the kidney that renal tubular threshold is exceeded. So, sabihin, hindi na kayang salain ng kidney mo yung glucose. So, mayroon kang excess glucose ngayon. Kailangan iihin na that you call it your glycosuria. And by the virtue of osmotic diuresis, papasok ang tubig, it will favor water retention in the tubules, so that you're causing polyuria. Marami ka kasing iniihi. Now, once you have renal water loss plus hyperosmolarity due to hyperglycemia, it will trigger your thirst receptors in the brain, causing polytipsia. Kaya, malakas uminom ng tubig ang mga diabetics. And then, once there's deficiency in insulin, there's a change of state from anabolic to catabolic, and then the proteolysis now occurs, releasing gluconeogenic amino acids from the liver as building blocks of glucose. So, gamitin ngayon yung amino acids in the liver, convert nyan to glucose, there's a negative energy balance, and therefore, there's an increase in appetite, causing polyphagia. So, yun ang three classic symptoms natin. However, pa nag-progress, despite increased appetite, the catabolic effects prevail. So, You may see weight loss and muscle weakness in some patients na merong DM. That's not unusual knowing the pathophysiology of diabetes. So this is a nice diagram from Robbins showing you the three different the development of the or classic triad coming from a state of insulin deficiency and or insulin resistance. So reviewin nyo na lang to on your own. So, the main acute metabolic complication, kinakatakutan mo acutely is diabetic ketoacidosis. And this is a severe acute metabolic complication of mainly type 1 diabetics, pero this may also happen in type 2 DM. The most frequent precipitating factor is the failure to take insulin. So remember, in these patients, kailangan nila ng exogenous insulin para mawala ang hyperglycemic state nila. Ma-transfer yung glucose from the blood to the peripheral tissues. But there aside from taking insulin, there are other triggers, pwedeng infection, other illnesses, trauma, and certain drugs. And this is mainly associated with epinephrine release. So, once epinephrine is released, it will block residual insulin action and stimulates glucagon release. So, in other words, you are promoting a hyperglycemic state as well pag may epinephrine ka. Okay. So, pag mayroon kang insulin deficiency and glucagon excess, you have decreased peripheral utilization of glucose, increasing gluconeogenesis, and that increases your hyperglycemia to levels of 250 to 600 milligrams per deciliter. So, kasama ng diabetic ketoacidosis is the increased synthesis of ketone bodies. Kasama yan doon sa effects niya. So, what happens in here? The free fatty acids in the liver are esterified to fatty acyl coenzyme A. And this causes oxidation within the hepatic mitochondria producing your ketone bodies. And at this state of insulin deficiency, mas mataas na ang formation ng ketone bodies mo compared to its rate of utilization. So, may accumulation ka of ketone bodies causing your ketonemia and ketonuria, which is why if we're going to diagnose diabetic ketoacidosis, you need to check the level of ketones sa urine. Kasama siya ng routine urinalysis. If urinary excretion of ketones is compromised due to dehydration, that causes the condition known as metabolic ketoacidosis. Now, the clinical features would include fatigue, nausea, vomiting, severe abdominal pain, fruity odor, and the characteristic Kussmaul breathing, which is deep labored breathing. And if left untreated, it will cause depressed consciousness and coma. The treatment for this condition, for diabetic ketoacidosis as a whole, is to give insulin, and then you correct the metabolic acidosis and treat possibly kung merong siyang underlying factors such as infection. In type 2 DM, DKA or diabetic ketoacidosis can occur pero at a lower frequency due to higher portal vein insulin levels. For type 2 DM, however, instead of DKA, what can happen is a hyperosmolar hyperglycemic state due to dehydration due to sustained osmotic diuresis. This happens when your patients do not drink enough water to compensate for urinary losses. It is seen in older patients with diabetes and patients disabled with stroke or something similar and cannot maintain adequate water intake. So, the delayed treatment for this condition occurs due to absence of ketoacidosis and its symptoms. Hyperglycemia in these patients are more severe than DKA. Ang levels of blood glucose is around 600 to 1,200 milligrams per deciliter. For both of these conditions, the most acute metabolic complication is your hypoglycemia. Not just for DKA and HHS in general, pero for diabetes, acutely, ang pinaka-problema mo, hypoglycemia. Di ba parang parang paradoxical siya na ang problema mo, hyperglycemic ang patient mo. Pero actually, ang mas kinatatakutan mo is hypoglycemia in DM patients. Bakit ka nagkakaroon ng hypoglycemia? You're missing a meal, excessive physical exertion, and excess insulin administration for those taking exogenous insulin. So, symptoms would include dizziness, confusion, sweating, palpitations, and tachycardia. Management is by giving oral or IV glucose. Kaya, one of the more famous people here, the local celebrity that has diabetes, is Gary V. And in one of his interviews, na-mention niya na because he is diabetic at minsan 'di ba high energy performance siya, then after the performance, syempre bagsak ang glucose levels niya. Kaya siya kailangan sabi niya may dala-dala siya ng Coke parate para yun yung pang offset niya ng glucose. You will notice that, and I notice it too kasi I'm diabetic as well. Nakapag dire-diretso ako nagtatrabaho na ganyan at there will comes a point in time na talagang masakit na ng ulo ko, and talagang it will be relieved by simply eating something with sugar o kaya carbohydrates such as rice, ganon. Kaya ito ang kinatatakutan nyo for hypoglycemic. Minsan, you will encounter this sa ER. Pag kayo mismo yung doctor, minsan a patient would just come in and they will be hindi na sila makagalaw, ganyan, tapos hindi mo sila makausap. Pero pag inject mo ng D5 water, yung dextrose, di magre-recover sila seemingly. And that's just simply because hypoglycemic lang pala ang pasyente mo. So, how about chronic complications of DM? Kanina, we were discussing acute problems. Yun yung mga emergencies mo in DM. Now, we're dealing with chronic complications. The morbidity in DM is mostly associated due to large or medium-sized muscular arteries and in small vessels. So that's why you have your diabetic macrovascular or microvascular disease. For macrovascular disease, this occurs due to accelerated atherosclerosis, and your patients will have an increased risk of MI, stroke, and lower extremity ischemia. For microvascular disease, your patients can have retinopathy, nephropathy, and neuropathy. So, this one is a nice diagram showing you all the possible chronic complications of your DM. And we'll go over these one by one. Kasi, in your practice, ito ang makikita nyo most of the time. How do these complications occur? Basically, yung pinaka-problem mo is glucotoxicity. So, glucotoxicity is responsible for the long-term complications of DM. So, how do you assess ngayon glucotoxicity? So, ibig sabihin, you need to have some way of measuring long-term glycemic control. So, this is why we use glycated hemoglobin or HbA1c. Now, HbA1c is formed by non-enzymatic covalent addition of glucose moieties to hemoglobin in your red cells. So, since nakakabit siya sa red cells ngayon, and remember that red cells can only live up to 120 days, ibig sabihin, you can measure the glucose control of your patient depende sa dami ng kumabit na glycated hemoglobin in a period of 3 months. Kaya yan ang sinasabi. Kaya for ang conventional DM, yung for example, type 2 DM, type 1 DM, ito ang magandang i-measure. Pero if we're measuring GDM, if we're trying to diagnose GDM, gestational diabetes mellitus, this is not recommended ang paggamit ng HbA1c. You still rely on your FBS and your oral glucose tolerance test. So, there are other ways of measuring glucose over long term. Merong mga continuous glucose monitoring systems. Pag yun ang gagamitin mo, you just have to make sure that your glucose levels is between 70 to 180 milligrams per deciliter. So, ano ang mechanism ng mga complications natin? Okay, so, you know how to diagnose. So, how about the complications? How do these complications occur? In general, if you are in a state of hyperglycemia, there is increased flux through metabolic pathways that generate harmful precursors, causing your end organ damage. There are different mechanisms of doing it. One is the formation of advanced glycation end products or AGEs. These are a result of non-enzymatic reactions between your glucose-derived metabolites and amino groups in intracellular and extracellular proteins. The rate of formation of your AGEs is accelerated by your hyperglycemia. The AGEs now bind to a specific receptor known as your RAGE or receptor AGE expressed on your macrophages, T cells, endothelium, and vascular smooth muscle. So note na all these things you can see it in your blood vessels. So kakabit yan ngayon yung itong AGEs ngayon doon ngayon sa mga structures na to. And the detrimental effects of your age-rage signaling axis in the vascular compartment include release of cytokine growth factors, generation of reactive oxygen species in your endothelial cells, increased procoagulant activity on endothelial cells and macrophages, and enhanced proliferation of vascular smooth muscle cells. So in other words, kakabit itong age na to on these things which can be found in the lining of your blood vessels. Pag na-accumulate ngayon yan dun sa blood vessels mo, you have atherosclerosis basically. Another thing that age does is it can directly cross-link extracellular matrix proteins. Eh, pag nagkaroon ka ng cross-linking ng proteins mo, it favors the accumulation of said proteins. Okay? So, example niyan would be your plasma proteins such as albumin, which is found in the basement membrane of small vessels. Pag kumabit ang age doon, favor accumulation, magkakaroon ka ng blockage that causes your microangiopathy, essentially. Activation of protein kinase C is another mechanism in which you have a calcium-dependent activation of your intracellular protein kinase C and the DAG. It's a very important signal transduction pathway. So, if you have intracellular glycemia, it stimulates the synthesis of DAG from glycolytic intermediates plus excessive PKC activation, production, and then that results to the production of VEGF, TGF-beta, and protein plasminogen activator inhibitor 1. Now, this one is very important, yung production of VEGF, kasi one of the feared complications of your diabetes is retinopathy. And kasama doon would be ang hallmark niya is neovascularization of your blood vessels. So, yan yung effect ng activation ng protein kinase C. Makikita nyo doon sa mata. Other methods would be your oxidative stress and disturbance and polyol pathways. Nandito bali yung pag-accumulate ng sorbitol. And sorbitol accumulation in the eye causes your cataract formation. So, yan yung basic mechanism mo dyan. And another mechanism is via your hexosamine pathways and generation of fructose 6-phosphate. So, yun yung mga different mechanisms mo for the complications of your DM. So, how would DM look like this? How would the complications, morphologically speaking? So, remember na your main pathology right now is in the pancreas. So, what happens in the pancreas? If you're dealing with type 1 DM patients, you will see reduction in the number and size of the islets, or you may have insulitis. So, meron kang, makikita mo yan, meron kang chronic inflammation in your islet cells over here. Sometimes, in type 2 DM naman, what you may see instead is amyloid deposition in the islets. We'll see that later. And for those non-diabetic newborns of mothers with diabetes, you will be able to see an increased number and size of the islets as compensation for the hyperglycemia. Kaya actually, based dito, sa finding na to, one of the suggested na mechanisms for treatment would be your transplantation pancreatic transplantation para mag-normalize ang beta islet cells mo, but it's still something to be studied pa. You've seen this earlier in DM. So, in DM type 1, so ito yung mga glucagon cells mo. Parang hina-highlight lang niya na nandito yung yung islet cells mo. And in type 1 DM, wala na siya. Dito sa part na to. Okay, so this one is type 2 DM. So, remember in type 2 DM, you may see amyloid accumulation. So, ganito makikita mo sa islet cells. You will see amyloid over here. And then, when you use your Congo red stain to visualize your amyloid, you will be able to see your apple green birefringence. For diabetic macrovascular disease, I mentioned kanina, di ba, na basically, your AGEs are the ones cross-linking proteins, and the AGEs is the one being lined up in your, in the basement membrane ng blood vessels mo. So, because of this, meron kang endothelial dysfunction, and that predisposes the patient to atherosclerosis and other cardiovascular morbidities. The main hallmark is accelerated atherosclerosis involving the aorta and large and medium-sized arteries. So, remember ha, ito lang ay manifestation ng DM. But these things can still be found in conditions na not diabetic. So, if you're working na pabaliktad, hindi porket nakakita ka ng gantong klaseng pathology, ibig sabihin may diabetic automatically ang pasyente mo. Okay? Remember, the morphology of atherosclerosis is just the same as our conventional atherosclerosis. And the problem is that when atherosclerosis occurs in your coronary arteries, it causes MI. Other findings include gangrene of the lower extremities. Now, this one I have seen a lot because pag nagkakaroon ng amputation case, it has to be seen by a pathologist. So, we see these the ones that we really inspect. So, ako, personally, if I received an amputation specimen, I try to find the blood vessels and kakapain ko sila kung saan yung area ng matitigas. Nandun usually ang level of occlusion causing your diabetic macrovascular disease. Okay. Other findings, atherosclerosis of the large renal arteries and hyaline arteriolosclerosis in your renal vessels as well. So, another consistent morphologic feature is the diffuse thickening of your basement membranes. Now, this is quite evident in the capillaries of the skin, skeletal muscle, retina, renal glomeruli, and renal medulla. So, this is what you will see over here. This is an electron micrograph. You will see over here the thickened basement membrane, itong one with B. And if you do a special stain, a PES stain, you will be able to see thickening of your basement membrane over here. And this is in the glomerulus. So you will be this is in your tubules pala. It's not in your glomerulus. So yung tabi ng glomerulus, pag nag-PES ka, makikita nyo yan, accumulation ng kumakapal ang basement membrane mo. Okay? Now, because of this is what you will see in diabetic nephropathy, retinopathy, and some forms of neuropathy. For DM retinopathy, remember that renal failure is the second most common cause of death due to DM. The most common cause of death is still MI among diabetics. So, you have three main lesions over here. You have glomerular lesions. So, basement membrane thickening. Ayan siya. This one is nodular glomerulosclerosis. As you can see over here, ito yung Kimmel-Stye-Wilson lesion mo. You can also have renal vascular lesions, principally arteriolosclerosis. And you may also see pyelonephritis. So, for capillary basement membrane thickening, it will occur in all cases of DM nephropathy and best appreciated using an electron microscope. So, you will see mediastinal widening and thickening of your basement membranes, such as what you see over here. You can have diffuse mesangial sclerosis. So, yung mesangium mo, which is the areas in between your capillary loops over here, they may be a diffuse increase in that area as well. And they can be PAS positive, as you can see over here, and will have a nodular appearance. That is your Kimmel-Stye-Wilson lesion, as I've mentioned earlier. So, ito yun, nodular glomerulosclerosis. They take the form of ovoid spherical laminated PAS positive nodules at the periphery of the glomerulus. And these nodules show features of mesangial lysis, in which there is disruption of the anchoring interactions between capillaries and the mesangial stalks. And this contributes to the formation of your capillary microaneurysms. Within the arterioles, you may be able to see hyalinosis. So, meron kang hyaline material as well that you can see in the capillary loops or in the Bowman's capsule mismo. Other findings sa kidney, as I mentioned earlier, renal atherosclerosis and arteriolosclerosis, and then your pyelonephritis as well. So, especially chronic pyelo, this is common na finding. So, yung tong mga combination of findings na to, if you're just given an autopsy, walang history, you may suspect DM in your patient. For the eyes, you may have cataract formation dahil nga sa sorbitol accumulation. You can have glaucoma due to increased intraocular pressure, and if that is left alone, that may cause damage to your optic nerve. And then here on the right over here, this is an example of a retina with DM retinopathy. So this is more explained in the chapter of eye, pero what I'm going to tell you is the prominent features in diabetic retinopathy would have to be neovascularization, microaneurysms, edema, and exudates, as we have seen earlier when we were trying to explain the the mechanisms behind the chronic complications. So this one is an effect of peripheral neuropathy. So what happens is, in neuropathy is nagkakaroon usually stocking pattern ito. So sa paa minsan the nerves are rendered nawawalan ka ng feeling of sensation. So minsan nakakatapak yung mga pasyente mo ng pins. Tapos napapabayaan sila. That's why, for diabetic patients, you need to do a microfilament test as well to check for sensitivity ng peripheral vessels mo. Just to make sure that they still have feeling. Kasi pag wala na, that is an increased risk for infection. Dahil di nila nararamdaman na may sugat na pala sila. So pag ganyan at napabayaan yan, the management would have to be, I think if as simple as this, if it's just like this, I think kaya pa niyang i-debride. Pero pag masama na yan, as in like there may be loss of phalanges. We've seen that often. Mauuwi ka sa amputation just to make sure na wala kang foci for sepsis. The clinical manifestations, many of your morbidities and mortalities secondary to long-term effects of DM, you will be able to see them around 15 to 20 years after onset of hyperglycemia. So macrovascular complications, as I mentioned earlier, are the most common causes of mortality. Pinakamataas na risk is for coronary artery disease leading to MI. DM nephropathy is the leading cause of end-stage renal disease. So, the earliest manifestation of this would have to be microalbuminuria. So there is a test to do this. You have to specifically request it sa laboratory in order to get you microalbuminuria levels. If without interventions, 80% of type 1 DM and 20 to 40% of type 2 DM patients will divert overt nephropathy with macroalbuminuria already. One of the feared complications is the visual impairment and blindness. So 60 to 80% develop DM retinopathy mainly due to neovascularization. So yun yung i-explain ko din kanina. Management for these would have to be anti-angiogenic agents. So mga anti-VEGF na medications. Other findings I've mentioned earlier, you can have cataracts and your glaucoma. Diabetic retinopathy, neuropathy results in the damage to the CNS, peripheral new sensory motor nerves, and autonomic nervous system. We usually see this as a distal symmetric polyneuropathy of the lower extremities. Pero pwede din pati sa kamay makaapekto. Other things that may involve would be the autonomic nervous system. So that may cause disturbances in the bladder and bowel movement and erectile dysfunction. And of course, in DM, dahil nga meron kang compromised na vascularization, you have an enhanced susceptibility to infections of the skin, TB, pneumonia, and pyelonephritis. And that is causing around 5% of all the deaths related to DM. So maraming mechanisms on how they achieve this, pero the known ones are the decreased neutrophil function, impaired cytokine production from macrophages, and vascular compromise, as I said earlier. Now, kaya pag meron kang pasyente na may diabetic, talagang kailangan PE from head to toe. history from head to toe yan. Kasi you want to be able to document kung meron na ba siyang ganitong manifestation and that. Kasi you have to individually address each of those complications. For DM retinopathy, this is one of the images that we were able to get regarding the distribution ng affected na nerves. So, ito yung pinaka-common would have to be here in A. Okay? This is the glove and stocking pattern, but you may also have involvement of other parts and even in the internal organs may be affected as well. So, how do you manage DM? Now, this is, maraming guidelines on how to do this, but the main treatment strategies are listed here. So, it has to be maintain glycemic control, dietary modification, exercise, and weight loss regimens. Okay. So, you may, for your main strategy dyan, papasok yung, pharmacologic and non-pharmacologic treatment. And those will have to advice to your patient holistically. Kailangan maintindihan ng patient nyo is that DM is lifelong. Hindi ka pwedeng uminto sa pag-inom ng gamot porket normal na yung blood sugar levels mo. Okay? So that's it for DM. We'll proceed with pancreatic neuroendocrine tumors in the next chapter of this lecture.